I'm excited for this panel. We have a conversation around seizure management. We have Dr. John Schreiber, who's here. He is the Associate Chief of Neurophysiology, Medical Director of EEG and the Epilepsy Monitoring Unit, and the Director of Epilepsy Genetics at Children's National Hospital. He serves on the Pediatric Epilepsy Research Consortium Board, is the co-chair for the Investigators Workshop Committee of the American Epilepsy Society, and serves on several other advisory boards. Please join me in welcoming Dr. Schreiber.
There we go, that works. Okay, this is my first NBIA Disorders Conference, so I want to just thank everyone for welcoming me down here. It's been a great community, a great organization. I've been sort of on the periphery for a few years now, and worked some with Dr. Hayflick and her group and sending her people, and particularly involved now as I've had some patients with BPAN. So really excited to talk with you today. I'll share this is more about epilepsy and seizure management in general. We're learning more and more about seizures and epilepsy presentation in NBIA disorders, but I think there still is a lot to be uncovered, and just really excited to see all the great work and everything going on here that you all are contributing to. Some disclosures which aren't really relevant to this talk. So we'll talk about seizure and epilepsy terminology. I think many of you are very familiar with the terminology we use to describe seizures or different kinds of epilepsies. It can be important, though, for determining treatment and other options. Talk about seizures and epilepsy and NBIA disorders specifically, talk about our evaluation, and then discuss management. So first, some terminology and epidemiology, so how do seizures present? The seizure is a disturbance in the electrical activity of the brain that is associated with a clinical change. So usually some kind of behavior, some sensation, something that accompanies that abnormal synchronized activity in the brain. This all comes from the Institute on Medicine's report a few years ago. And epilepsy is a very broad definition. All it is 2 or more seizures that are unprovoked, that are separated by more than 24 hours. There is more recent research and operational definitions suggesting that you might call something epilepsy if you had 1 seizure, and your probability of having more is about 60%, recognizing that that's often the point at which we may consider starting a medication. So some kids say, those with BPAN that have 1 seizure, your likelihood of having more seizures at that point is actually quite high. So we may actually start a medication after a first seizure for kids with particular diagnoses. So overall, epilepsy itself is not uncommon. There's 2.2 million people in the US, now this number is probably more, and more than 65 million worldwide. Annually, there's 150,000 new cases of epilepsy diagnosed in the US annually, and 1 in 26 people in the US will develop epilepsy at some point in their lifetime. So epilepsy itself is not terribly uncommon, but there are many, many different causes of epilepsy. If you look at our top neurological disorders, it's number 4 on the list there, so actually very common. Doesn't get as much funding as some of these things like stroke and Alzheimer's disease, for instance. And then if you look at when it presents, it tends to present early and later in life, and those are for different reasons. And then actually it kind of drops in late adolescence and in middle age, and you probably see that in some of your kids. We'll talk about that some too. So seizures are classified according to where their presumed onset is. So we call seizures as being focal in onset. You might hear the term partial. The old terminology was partial. Now we use the term focal since 2017. These definitions came out. Or generalized, which means they appear that they occur all over the brain at the same time, synchronously, or some that are unknown onset. And focal seizures can be either of one of 2 overall types. Either they're aware or impaired awareness, and that corresponds to the old terminology, which was complex partial, which means focal impaired awareness, or simple partial, which is the same as focal aware. So if that's confusing to you, don't worry, it's also confusing to many doctors. But they change the terminology every 5 to 10 years just to keep people on their toes. I think this also it's more descriptive, it's kind of more accurate, so I think that's the real reason. But it is confusing to everyone who doesn't do this on a daily basis. And then generalized onset, you can have seizures of very different types. So the classic grand mal is generalized tonic-clonic, where you've got a tonic phase where you stiffen, and then you progress into the clonic phase where you've got this symmetric jerking. You can have absent seizures, which are just staring. And those are also generalized seizures. They appear to occur in the brain synchronously all at the same time. And again, that's a generalized seizure, which sometimes can be mistaken for focal impaired awareness seizures that also can present with staring. But the focal impaired awareness seizures are usually longer, not as discrete onset and offset, and may have other accompanying signs to them too, like twitching or jerking or chewing movements and that kind of stuff. So this is when your neurologist asks you these questions to try to kind of get at, what do these seizures look like? I feel like sometimes I'm badgering people when I'm trying to get a story of what exactly did these seizures look like, so we can determine just this, what type of seizure is this, because then that really informs our treatment. Videos too can be helpful. So many of you often bring videos with you to visits, and that's actually really helpful, to see them on video. Not that you have to catch them on video, and if you miss them, it's okay. But it can be useful sometimes to take a look at that and see what these seizures look like, so we can get at that underlying diagnosis. And then we have seizure terminology, seizure classification, then we go into epilepsy classification, and there are specific types of epilepsies, just like you can have focal or generalized seizures, you can have focal and generalized epilepsies, and then there's certain epilepsy syndromes. I'll talk about a couple of these because I think you'll see these come up in NBIA disorders, namely West syndrome or infantile spasm syndrome, and Lennox-Gastaut syndrome. So I'll chat about those again in a minute. Again, terminology keeps changing. This has changed somewhat, and there are different terms, different seizure types that can present at different ages. This actually is a really good resource if you're interested. It actually can be useful for clinicians, but the International League Against Epilepsy is the organization that oversees this classification and terminology, and has pretty good descriptions of all these seizure types on there. And this is the latest iteration of the epilepsy definitions. The panel on the right here are those that are considered to be developmental and epileptic encephalopathies, where you have some component of a developmental difference and an epilepsy syndrome that accompanies that. Again, I'll highlight a couple of these epilepsy syndromes later on in this talk. So moving on, and I'll take questions at the end too. Should be enough time for questions, and I'll stay along a little bit later as well. So a normal evaluation, when somebody presents with a seizure, if you have a known diagnosis of NBIA, you might not have as extensive an evaluation as you otherwise would. I expect that everybody, though, would get an EEG or an electroencephalogram that shows you brain activity, and that can help us determine seizure type, where things are coming from. What's your risk for additional seizures? It's useful for many reasons. Neuroimaging, obviously, we like to get a picture of the brain, typically with an MRI. And sometimes we'll do some laboratory evaluation. If you happen to make it to the emergency department, you can't walk out of the ED without having a basic metabolic panel and a blood count. So you'll get those things. Often not terribly useful, except in certain situations, especially if you're young kids. If you have a new onset seizure, those sometimes can be due to electrolyte imbalances. And then sometimes we'll do a continuous video EEG. Many of you may have experienced this, and there's different reasons to do that, right? To diagnose seizures, to distinguish seizures from other events. We know that a lot of movements can mimic seizures, and it can be hard to distinguish those things. Sometimes we just want to get a more yield. The longer you do an EEG, the more likely you are to pick up an abnormality. And sometimes it can be helpful to get sleep as well. There are other, just to mention, other disorders that can look like seizures and can sometimes mimic that. Some things I think particularly relevant to this group are myoclonus, or jerking movements, which sometimes can be normal, sometimes not normal. Shivering episodes in babies, reflux, which a lot of kids are often misdiagnosed as having reflux or Sandifer syndrome when they're babies. They're actually having tonic seizures. Breath-holding spells, and then movement disorders of various types, and I don't have to tell this group about that. So the risk of, this is overall, this is not NBIA disorders, but this is your risk of recurrence after a single unprovoked seizure. And when I say unprovoked, I mean not provoked by a fever in a kid who's 6 months to 6 years old, not provoked by an acute head injury. So if you have an unprovoked seizure, your risk of a second seizure is about 30–40% or so. If you have a second seizure or a third seizure, your risk of more seizures at that point is much, much higher. That's why in pediatrics we'll often wait until someone has a second seizure before starting an anti-seizure medication, unless your child has a disorder that has a very high risk of seizures, in which case sometimes we will start a medication after the first. Okay, EEG can be useful here as well. So if you have a normal EEG after that first seizure, your chance of having more is about 30%. If it's abnormal, say there's slowing in one part of the brain, or overall, that risk goes up a little bit to say 40–45%. And then if you have an epileptiform EEG, meaning we see a change on that EEG, like a spike or spike wave discharge, a change that's associated with seizures or epilepsy, that risk for additional seizures goes up to about 60% or so. So this is one of the reasons why we do EEG as part of that evaluation. We've gotten this question too, so that's when we start medications. When do we withdraw medications? Well, we do sometimes withdraw medications. It's always nice to be able to take somebody off medication if they no longer need it. The challenge is it's hard to know when someone needs it. Overall, the sage advice has been, if someone's seizure-free for 2 or 3 years, if you do an EEG and the EEG is normal, this is for, again, for somebody, the general population with epilepsy. After 2 or 3 years, if you were to taper them off an anti-seizure medication, their risk to have recurrent seizures is about 40%. So less than 50–50 that they would have seizure recurrence. There are some other factors that can play into that. So you'll see here, this is an article that came out a few years ago. There's other things you might consider, such as what's the duration of your epilepsy, how many medications have you been on, what was the age of onset, do you have a certain type of epilepsy that you're likely to outgrow. We think about all these factors when making a decision whether or not to taper an anti-seizure medication. But it is something worth considering. There's no right way to taper medications either. Some guidelines came out looking at quick taper versus a long taper. There's really not any one way to do it or right way to do it. I think that's something to have a discussion with your doctor about when and exactly how to taper a medication. One advice I do give people, if they are tapering medication, they have a trip plan, just wait to taper the medication until after you're back, because you don't want to disrupt things too much if that happens. Other evaluation, there's been an explosion of the use of genetic testing, or genetic diagnoses at least, in epilepsy. We now know of over 900 different genes associated with epilepsy. This again may not be so relevant to this group since you already know your genetic diagnosis, but suffice to say it's being used a lot more, so certainly in major academic centers. And when we do find a cause, there is evidence that this results in changes in management, and those changes in management typically lead to better outcomes. So hopefully we're going to see this employed more and more in usual practice for epilepsy management. I mentioned this, now we have over 900 genes that are known to be associated with epilepsy. And the challenge is now finding out what do we do about that when we get an answer. If we can develop precision therapies that can help to address these seizures and other symptoms that can accompany epilepsy. On to management. So medications, we have now around 30 anti-seizure medications. You'll see we still use phenobarbital, which has been around for over 100 years now, and there's really no good evidence that, in general, that any one of these medications is better than another in terms of controlling seizures, with a few notable examples. So there are certain epilepsy types or epilepsy syndromes where specific medications or groups of medications do demonstrate improved efficacy over another class of medications. Some epilepsies where specific medications can make things worse. So again, it is helpful to define the epilepsy syndrome to help with medication choice. I just spoke about this briefly, but again, this shows overall similar efficacy for multiple different medications in, I think this study was done in adults with focal epilepsy. What's really different is the side effects. So when we're starting a medication, our medication choice is often driven by the seizure type, the epilepsy type, and then what are the potential adverse effects. If you've got a kid who has a hard time gaining weight, You may want to stay away from a medication such as topiramate, which is known to be an appetite suppressant, for instance. We generally try to choose medications that have fewer side effects, and recognizing that a lot of them can be otherwise fairly equal in terms of efficacy. I'll say they're equal overall on average in terms of efficacy. You do find a lot of kids, though, that respond much better to one medication than another. So that is one other principle to keep in mind. You may find for your kid they respond much better to one medication than another, although overall the efficacy of these drugs for the larger group with epilepsy may appear to be similar. We titrate medications up to a therapeutic range, some kind of therapeutic dose. I don't know exactly what dose of medication is going to be the right dose for that child a priori, right? I don't know before I've had the benefit of seeing the impact on that child's seizures exactly what dose is going to work. So it is, in that sense, there's some trial and error to this, and that's frustrating. It's frustrating for parents. It's frustrating for us, too. There's no biomarker. I can't do an EEG and say if this medication is working or not. There's no other test to say if a medication is working or not, other than to have the benefit of time to see if it has an impact on a child's seizures. You can see seizures change, too, as you start a medication. You might have experienced this as well. If you start someone on a medication, particularly if they have focal seizures, and you find that they look different, sometimes it's because it changes how those seizures spread or limits the extent to which they do spread. But that can be disturbing and scary sometimes to see that. We will often need to change medications. If we do, you'll find quite often that you're on 2 medications at once or more as we start one medication and then hopefully reduce that next medication. There's always issues with polytherapy. The more medications you're on, the more likely you are to experience side effects, and the more likely those medications are to interact. So you always want to think about your goals of treatment. Quite often, starting another medicine or increasing a dose of medication may not be the right answer. You really need to balance the seizures with the effects of medications. We found, I alluded to this yesterday, some work we've done that the quality of life may actually correlate better with less anti-seizure medications than less seizures in some cases. And then we'll talk about seizure action plan, rescue medications. I think it's always good for people to have a rescue plan and a seizure action plan, to have a sick plan, what you do, because that often illness can increase seizures. So what do you do during that period of illness? And then stopping medications, which we talked about briefly. Women of childbearing age, I put this in there, just have additional issues one might think about in terms of risk to a developing fetus. There's things to think about in terms of contraception and medications. If you are on oral contraceptive pills, that can change levels of some anti-seizure medications, so important to think about these interactions if your children are taking any of those medications. Dietary therapies, some of you may have also gone through this, but there's different forms of dietary therapies for epilepsy. There's the ketogenic diet, there's MCT oil, there's low glycemic index therapy, and modified Atkins diet. So these are all kind of versions of that. The ketogenic diet is usually the most restrictive. A lot of places will have their own ketogenic diet program, which is largely managed by usually an epilepsy specialist and then a nutritionist. We have one where I am, and it's not one we go to first because this also has side effects. You need to monitor other labs, can have issues with constipation and other problems there. It can be hard to do sometimes, easier if you have a G-tube, but this can also be challenging and not something that we typically go to first. The other thing about the diet, now we used to start the diet back when I was in training on the inpatient side, so people would come in, they'd fast, we'd start them on the ketogenic diet over, I think, 3 or 4 days. Now we often start it as an outpatient over weeks, oftentimes, and increase the ratio of fats to carbohydrates and proteins gradually. It can take some time to see the effects. We really say it takes at least 2 months to see the effects of ketogenic diet on seizures. And it's important to recognize that there may be some delay in response there. But this can be useful for multiple forms of seizures in intractable epilepsy. There's now devices too, and I know people have been interested in this and asked about VNS number 1. So VNS has been around since the 1980s. It's also a treatment for depression. We use it a lot for epilepsy. It's a surgery, and I think that can be a hurdle for some people, but there's actually overall the statistics in epilepsy. I think it's if you have epilepsy, your chance of having surgery is about 30% anyway. Other kinds of surgeries, and I think if you have neurodevelopmental disability and another disorder, a very good chance you're going to have surgery for a significant surgery for something that could sometimes be seizure related. This is considered a minimally invasive surgery for a vagal nerve stimulator. You have a device that's implanted under the chest wall. There is a wire that's tunneled up and wraps around the vagus nerve and the neck, usually on the left side. And then the device is typically turned on a couple weeks later. Just like a medication, it's titrated up, so you increase the amount of current that's applied to that wire. And it's the usual settings. It's on for 30 seconds, off for 5 minutes. We can manipulate that and change the percent of time that the device is on and the time it's activated. You increase the amplitudes to a certain level, and then it remains there and remains on, and usually we have to replace the battery every 5 or so years. Newer devices, you can actually change the stimulation during the day and at night. So if you have more seizures at night, you might actually have different settings at nighttime. One of the good things about VNS is that it doesn't tend to have, it has side effects, but it doesn't have some of the same medication side effects that you may see from drugs. So it doesn't tend to be sedating, which is good, and can also kind of limit other medications. So it may also allow you to taper off other medications, especially if it's working. It also has a magnet, so you can swipe a magnet over the device and send a slightly higher impulse after you swipe that magnet to stop or interrupt a seizure. There are side effects to it, so cough, change in voice, sometimes increased sleep apnea. I've seen it affect kids, oral intake, presumably because of throat pain or other discomfort. So it's not without side effects, but typically different from medication side effects. There's also deep brain stimulation and responsive neurostimulation. We are using both of these in epilepsy of various types. Traditionally, responsive neurostimulation, or NeuroPace, was approved for the treatment of focal epilepsy with 1 or 2 foci in the brain, that you could implant electrodes there and use it. It's often being used off-label now for pediatric epilepsy as well, and targeting deep nuclei in the thalamus in the brain to treat other forms of epilepsy. So you'll see this used more and more, I think. Cannabis, this was very big a few years ago in particular. So you'll certainly see this out there. There are 2 neuroactive components, THC and cannabidiol. Cannabidiol is now a pharmaceutical form of. This is from the initial open-label cannabidiol trial. Multiple centers involved in this, and actually went up to very high doses of cannabidiol. It's up to 50 mg per kg per day, which is about twice the dose that we use now. Actually a little more than twice the dose we typically use. It was mostly used for Dravet syndrome and for Lennox-Gastaut syndrome. Now it's also been approved for tuberous sclerosis, but particularly relevant to this group is the indication for Lennox-Gastaut. And you can see here typically resulted in decrease in seizure frequency. I'll highlight the data on Lennox-Gastaut. So these are patients who were very refractory to medications. They had an average of 6 anti-seizure medications had failed to control seizures. About half were administered Onfir, clobazam, and various other anti-seizure medications. And overall, here are the numbers. So particularly at the higher doses, you saw better efficacy there on the higher 20 milligrams per kilogram per day. So maybe a treatment worth considering. Among other things, there are many therapies you might consider for Lennox-Gastaut that I'll get into in a few minutes. There's side effects of this too, right? So side effects are very common side effects, and 10% or more were sleepiness, fever, which we see in a lot of clinical trials that comes up for whatever reason, diarrhea, decreased appetite. We certainly do see GI symptoms. You might think that a cannabis-derived product would result in increased appetite. This purified cannabidiol does the opposite, results in decreased appetite, can also sometimes cause hepatotoxicity. So we'll look at we'll look at liver and follow that, and there's less common side effects you see here as well. There are drug-drug interactions. The most important one to mention is clobazam. So if you also administered clobazam, expect that as you start pharmaceutical cannabidiol, that your clobazam levels are going to increase, and increased sedation that you see may actually be due not entirely because of the cannabidiol, but may also be due to increased levels of clobazam. So you may need to lower clobazam to kind of combat that. All right, I'll talk about some specific epilepsy syndromes. I mentioned infantile spasms. So those of you who've seen this, it's a very particular thing and important to mention because it's got a very different treatment. So this starts in infants. Usually in the first year of life, can happen up to the second year of life as well. And you can see spasms actually later in some NBIA disorders also. Usually it is trunk flexion and extremity extension that occur in clusters repeatedly, typically upon awakening, sometimes falling asleep. When they typically start and are happening really every single day. Most go on to continue to have seizures, often changing into Lennox-Gastaut later on. Most also have intellectual disability long term. West syndrome is this triad of spasms, psychomotor regression, and hypsarrhythmia, which is this particular pattern on EEG. And there's various genetic and structural causes to this. This is what we see on EEG, so it's a very particular pattern. You don't have to have hypsarrhythmia to have infantile spasms, and just because you have hypsarrhythmia doesn't mean that you are going to have infantile spasms. So these things often occur together, but they don't equate. Treatment is very different than most of our other epilepsy syndromes. So it's usually steroids, either ACTH or high-dose corticosteroids like prednisolone, vigabatrin, usually for tuberous sclerosis, although we do sometimes use this for other forms of infantile spasms. And sometimes, particularly if patients are intractable, we can use these therapies in combination. So corticosteroids and vigabatrin sometimes for people who don't respond. For steroids, we see a response in an average of 3 days, really fast. So we used to say come back and get an EEG in 2 weeks. We'll see if your EEG is better. This is one of the few epilepsies in which we also treat the EEG. We don't just treat the spasms necessarily. If you still have hypsarrhythmia on EEG, we will change your treatment or prolong your treatment course. But you really see a quick response, particularly to the corticosteroids. And some data from PERC, this organization mentioned before, was that we see much better effect for these therapies than we do for anything else. Lennox-Gastaut is a generalized epilepsy syndrome, typically tonic seizures, stiffening. And you can also have atonic or drops and sometimes atypical absence and other seizure types too. You can have focal seizures in Lennox-Gastaut. EEG shows a slow spike wave, so we'll often do an EEG to confirm it. And then you have intellectual disability or developmental delay and sometimes behavioral problems as well that accompany this. This is the EEG we see in Lennox-Gastaut. This is from a patient of mine, but generalized, I think you can appreciate that this is occurring all over the brain and slow spike wave. Treatment, again, fairly particular. There are medications that work better for Lennox-Gastaut, and they're listed here. You may recognize some of these. Already talked about cannabidiol, but there are some that are specifically approved for the treatment of Lennox-Gastaut syndrome. And then surgery, we already talked about neuromodulation. Corpus callosotomy can be used in Lennox-Gastaut, and it is actually often best for atonic or drop seizures. And then dietary therapies can be useful as well. Febrile seizures, I put this in here without knowing that it was a prominent seizure type, but the more I talk to people, the more it sounds like it probably is, where fever-induced seizures, which are very common overall. So 2 to 5% of children will have a seizure induced by a fever between 6 months and 6 years. We also use the term simple versus complex, so it gets a little bit complicated there again. But it's complex if it's more than 15 minutes, if it's focal, like just jerking on one side, or if you have 2 or more in 24 hours. And that means you're higher risk to develop seizures. We don't usually treat febrile seizures. Sometimes, again, if you have a very high risk for developing epilepsy because of an underlying genetic syndrome, you might. Often we don't. Tylenol, acetaminophen may decrease a risk for febrile seizures during that same illness, during that same period. But if your kid has a febrile seizure and then has another febrile seizure 3 months later, and then you check their temp, you find they have a temperature of 102, don't feel like you failed because there is evidence to show that treating with Tylenol or another antipyretic, anti-fever medication in another bout of a febrile illness doesn't decrease your risk for future febrile seizures, okay? That's what I tell parents. You can use acetaminophen, ibuprofen, whatever you want to use during febrile illnesses, but it's not going to necessarily prevent the febrile seizure from occurring. I don't feel like you failed. Overall, about a third have recurrence of febrile seizures. 10% have 3 or more. And I'll talk about some other management issues in the last few minutes here. So I expect if you have experienced seizures, that your doctors have talked to you about seizure precautions, namely avoiding being in water by themselves, right? So, I don't know how much that may or may not apply to your child, but it's a risk of drowning if someone is left alone in a tub or pool or something else. So I always tell folks to make sure you're monitoring a kid whenever they're in the water. If you're taking showers, showers are fine because the water drains from a shower, so they don't have to be monitored in the shower necessarily. And then we'll talk some about acute seizure management, triggers, missed medication is often a trigger. We'll talk some about seizure detection and monitoring, and then status epilepticus. So this is a seizure action plan. Your school might have their own seizure action plan. This is from the Epilepsy Foundation. And it goes over basic demographic information about your child, seizure types, so the school knows what to look for, what to recognize, how they respond to a seizure, this kind of basic first aid that people generally apply, and then a emergency or rescue medication down there at the bottom. And there's several options out there for rescue medication. It used to be until recently the only real option you had for rescue medication in children was a rectal medication. Now we actually have those nasal medications that are FDA approved all the way down to 2 years old. So it makes it a bit easier for schools and for kids. And then actually it was 6 years old until a couple months ago. Now it's down to 2 years old. Status epilepticus is what we're trying to avoid by using these rescue medications. So status is defined as a single seizure that lasts more than 5 minutes or multiple seizures without regaining consciousness. There's both convulsive and non-convulsive status. And overall, this is, not terribly uncommon, but thankfully fairly rare. The reason why you treat it 5 minutes is to avoid the seizure going on for 30 minutes or more. Because you'll note here is 30 minutes is when we can start to see some of these changes take effect, both in terms of their, changes in cardiovascular stability and respiratory function. There is some evidence that seizures that last more than 30 minutes can sometimes cause scarring in the brain, called hippocampal sclerosis. We are treating at 5 minutes oftentimes to avoid these seizures going to 30 minutes. And this literature is mostly on generalized tonic-clonic seizures, so those are really more the emergency to treat. The focal seizures, probably not so much, and I think you'll see everything shifted down to the right for a focal seizure. This really just applies more for the generalized tonic-clonic seizures, which are higher risk. I want to mention vaccinations. This is a question I often get. What is the risk of childhood vaccination and seizures? And what this study showed actually is there's no increased risk in the first year with vaccinations. If you wait until the second year, if you're delaying some of these vaccines, you can actually see an increased risk. And most of those are febrile seizures. Probably what's happening here is your highest risk for febrile seizures is at about 2 or 2.5 years. So there's a peak. Your febrile seizures kind of start at 6 months and they peak around 2.5 years, and then they decrease in incidence. So if you delay immunizations, it sometimes is giving those immunizations at a time when a child's at higher risk to have seizures. So I don't usually recommend delaying that. The only situation in which I will say to delay is if your child is being treated for infantile spasms, they're on steroids, they're not going to actually benefit from getting that immunization because they're not going to mount that immune response. You have to wait until they've completed that course of corticosteroids or immunosuppressive therapy. The Italians came out with some recommendations here and that basically vaccination should be performed without contraindication in children with epilepsy. Sometimes I will wait if someone has very poorly controlled seizures. You might wait until they get on a medication or something that better controls them before giving that. Other things to think about are complications. We'll just get into these. So you may be aware of or heard of a SUDEP, or sudden unexpected death in epilepsy. That's one of the causes of mortality in epilepsy. It's not the most common cause. The Swedes did a study looking at overall mortality risk in epilepsy and found that the adjusted odds ratio, so you were 11 times more likely to die if you had epilepsy prematurely than the general population. And a lot of those it was more often in people who had comorbid psychiatric disorders. There is something called SUDEP, or sudden unexpected death in epilepsy. We think it occurs in about 1 in 1,000 adults with epilepsy per year and about 1 in 4,500 kids with epilepsy per year. Maybe an increased risk in kids with certain neurodevelopmental disabilities. There's a very increased risk in some genetic epilepsies, some others that I follow. The things that can increase risk for SUDEP are, skip ahead here, the presence of generalized tonic-clonic seizures and nocturnal seizures really are probably the two biggest risks. Things that can decrease risk of seizures are medications to hopefully decrease the frequency of generalized tonic-clonic seizures, and some kind of device to monitor for seizures. There's different things that are out there. Sometimes a baby monitor could be appropriate. There's also some devices that are approved for kids who are 6 and above, approved by the FDA. So just last couple slides here. This is sort of small, I apologize, but this was from a review that looked at multiple different studies and just sort of combined everything here, looking at seizure frequency in various NBIA disorders. This just goes over some of the patient characteristics, many things that you know. I'll just kind of skip through these slides. This goes over just clinical manifestations and imaging findings. So if you look at the seizure prevalence reported in these studies, for PLAN, it was about 50% of kids. For BPAN, it was about 3/4 of kids. And then for other disorders, they're either not very high numbers there or reported less frequently, like for PCAN, only about 1/4, for instance. So for PLAN, you saw more generalized seizures. For BPAN, you saw various types. I mentioned infantile spasms and Lennox-Gastaut syndrome, but you can see multiple different types of seizures. This is something I'd like to understand more about, and talking with several of you today was very helpful. But I do think there may be some other seizure characteristics that we could glean from talking with you all and understanding more about this. This came from the group at OHSU. Jenny Wilson's the first author on this, so Consensus Clinical Management Guidelines for BPAN. And this is, again, sort of small here, but the thing to draw your attention to is that seizures are often mild to moderate in childhood. They often taper off in adolescence and are uncommon in adulthood. So that seems to be the clinical course, at least for BPAN. I had some epilepsy resources here on this last slide. Again, this is just for epilepsy in general. And just want to thank everybody for your attention. I'll take questions.
Can you talk a little bit more about Lennox-Gastaut, and then also, possible surgical interventions? Is it realistic? Is it kind of too much of a scope, too difficult to treat surgically?
So Lennox-Gastaut is one of those things that we do treat now more and more with surgery. And your goals for treatment with Lennox-Gastaut syndrome, because it is often an intractable form of epilepsy, at least for a period of time, is not necessarily, it's not to stop all seizures, right? We're aiming for quality of life. We're looking to keep, hopefully, seizures fairly brief, lower risk, try to avoid the generalized tonic-clonic seizures, keep kids out of the hospital, try to avoid, frequent use of rescue medication, and then trying to avoid medication side effects.
Yeah.
But surgery can be a part of that.
Okay.
VNS has been around now for a while, and one of the situations in which it's used most commonly really is for Lennox-Gastaut.
Okay.
And I looked at our own experience of genetic epilepsies, and it really mimicked the data you would see in the overall population, the people that got VNS, and it seemed like it mirrored. There was no one that stood out that this is much better or much worse for. There are certain seizure types for which it may be more or less beneficial. Myoclonic seizures, the quick jerks, may not be as beneficial for those kids if they have those a prominent seizure type, but often you're often not considering surgery in those situations. If atonic seizures or drops are much more common or more disabling, then I might consider like a corpus callosotomy, which seems preferable for that seizure type. But otherwise, VNS, and now perhaps DBS or RNS, responsive neurostimulation, may be options. Those are more invasive, though. So with DBS and RNS, you're doing surgery in the brain.
Sure. Thank you so much.
You're welcome. Thanks for the question.
I think yours was first.
Hi. So I know a lot of kids with BPAN, they can't tell us when they have a seizure, especially at nighttime. They're not going to wake us up and say, "Hey, Dad had a seizure," or "Something happened. I don't feel good." You already kind of answered my question. My first part of the question was, are there any devices for monitoring seizures? And then when would you recommend using or asking for a device that can monitor seizures? At what point would you recommend using them?
It's a great question, and one I think we struggle with all the time. Number one, it depends on the seizure type. So there is a device approved for seizure detection called EpiMonitor, which really is best. If you look at the data, it's best for convulsive seizures. If you shake, it was mostly for generalized tonic-clonic seizures. But if you have a seizure, shaking on one arm, it probably is good for detection of those seizures, more than 90% sensitive. Initially, it had more false detection, so it had like more false positives. You would have a kid who was just moving and it detected a seizure and would wake people up. Initially, I think it was about one a day. I think it's a little better than it was. But that is the device now that's approved out there. But again, best for convulsive seizure detection. If you're not convulsing, if you don't really have prominent motor manifestations with your seizure, there's not anything that's great for that right now. There are different devices people use, whether cameras. There's people who try like mattress monitors, pulse ox sometimes, but it largely depends on the seizure, the individual seizure characteristics. I've talked with other people that do research in seizure monitoring in SUDEP, and a lady from Sick Kids in Toronto had recommended what I did for years, which just use a baby monitor, which is not great, is not perfect. But in many cases, it may be the best thing we have right now. And you have to balance this too with, allowing your child needs to get sleep. You need to get sleep. The risk I'm talking about here, thankfully, the risk for seizures themselves, for individual seizures, are fairly low. With the risk for generalized tonic-clonic seizures and risk for status epilepticus, if your child has a history of status, particularly with generalized tonic-clonic seizures, that is a higher risk. If your child's only ever experienced focal seizures, that risk may be lower. So you have to balance that with you and your child's quality of life, I think.
Yeah. So our daughter has frequent, little blip absent seizures during the day, many, hundreds a day. And they put her on valproic acid. And it worked okay for a month and a half. And then they returned. And they increased her dosing. But when we increased her dosing, we saw pretty drastic changes in her behavior and emotional and very, easy to irritate. And I'm not sure whether that's just because she's 3 years old going on 4, or if it's the medication. So is behavioral changes with valproic acid something that is common? And is there a medication, what would be the least side effect medication that you could offer a child that's 4 years old to avoid that unwanted side effect?
It's a great question. So, any medication we give that reduces seizures it affects the nervous system. It can potentially produce behavior changes. The most common one is levetiracetam or Keppra, although a lot of kids do fine on that. Now, what I will say is I don't see behavioral changes start much later on, right? Usually if you are going to have a behavior change, it starts either when you start it or when you increase the dose, which was your experience. So if you've been on let's say you've been on a stable dose of valproic acid for 6 months and all of a sudden your child has a behavioral change, I'd be looking for other things. In terms of what medication choice is the best, I mean, that's hard to say. I think that's a conversation you have to have with your doctor. If you look at, there was a study, and this is a different population, but one of the very few studies we have on comparative efficacy of drugs in epilepsy is the childhood absence epilepsy study, and that looked at other kids with otherwise typical absence epilepsy who were started on valproic acid, ethosuximide, or lamotrigine. And if you looked at the efficacy, about 50% were controlled with either ethosuximide or valproic acid, but valproic acid had more side effects. And about 25-30% were controlled with lamotrigine, and that also had fewer side effects. So, I mean, again, I think it's worth a conversation with your doctor if you think your child is experiencing behavioral side effects, in particular if they start when you're starting the medicine or as you're increasing the dose.
Thank you so much. That is the end of our session. I know we could keep you here for another 7 hours and keep going. I would encourage you, if you still have questions, please come see Dr. Schreiber. But thank you. Have a wonderful evening. One last reminder that if you have thoughts on the conference, thoughts on some of the things that our organization is doing, the board will be at the happy hour at 6 o'clock, and we are so happy to talk to any one of you. Have a wonderful evening.